You know, the quantification of mitral stenosis is not as easy as it may seem at the first glance. We have a few numeric values which we can generate, which help us to classify the degree of severity, but these values are sometimes very unreliable. Again, as with other forms of valvular heart disease, we'll have to use an integrative approach. Okay, so let's start. I first want to start with the visual assessment of the severity. Can we actually use the 2D image? Well, yes and no. Basically, there are no distinct criteria which help you to grade the severity of stenosis, but it does give you a clue in which direction the severity is going. One thing, however, which you should never do is you should never use only one image or one cut plane. You should always use, for example, here a long axis view and a short axis view. In the long axis view, we nicely see the separation of the leaflets. However, we do not know where we cut the valve. Did we cut it more in the commissural region, or did we cut it more here in the middle? So the degree of separation also depends on where we cut the valve. Here in the short axis view, we get a very good impression of the opening motion of the valve and how large the orifice actually is. However, again, here we do not know exactly where the valve was cut. Was it really cut here where it is smallest, or further towards the left atrium? Here's another example. On the left hand side, a patient with severe mitral stenosis, and on the right hand side, moderate mitral stenosis. Note that we're not even able to see separation here, while we see a distinct separation here in this patient. So the 2D image does help you in a way. The 2D image can also be used to perform planimetry. If possible, planimetry should always be performed. In reality, it's the only direct calculation of the mitral valve orifice area. However, there are a few pitfalls and few things that you have to consider. The most important thing is, as already mentioned, you really have to align the transducer so that you have the mitral valve at its smallest opening in your field of view. If you cut the plane of the mitral valve more oblique, you will obviously overestimate the size of the mitral valve orifice. If I want to see if a student is good at echocardiography, what I let them do is I let them quantify the severity of pulmonary hypertension, in other words, get the TR signal. And the other thing I let them do is planimetry of the mitral valve. Why? Because both of these things are very difficult. Here's a demonstration which shows you why it is difficult. It's actually quite difficult to really perform planimetry of the mitral valve, and you have to consider a few things. The first thing, always look at the peristernal long axis view first, because there you get a good appreciation for the opening motion of the mitral valve. And in our patient here, let me see if I can get this a bit better, we can see that the mitral valve does open quite nicely. You see, the anterior and the posterior leaflet separate quite nicely, so it does not look as if stenosis is really severe. The other thing is, you can kind of appreciate in which intercostal space you should be. Because remember, you want to cut the mitral valve here at the region where the valve is the smallest, or the opening is the smallest. So if you have, for example, an image which looks like this, you will not be able to cut the valve exactly where you want to cut it in a two-chamber view, in a short axis view. So this also gives you a bit of a feeling where you want to cut the valve. And then you rotate the transducer into a short axis view and then scan the mitral valve beginning from the annulus down towards the tips of the leaflet until you find the region where the mitral valve opening is at its smallest. Okay, and then once you have that, you would freeze the image. I will now go to the images I stored previously. Okay, this is such an image. And then scroll to the region where the mitral valve opens the largest during the cardiac cycle, and then you perform planimetry. Here in our patient, it's possible to do that quite nicely. And what we get is an opening area of 1.8 square centimeters. So it really fits to the impression we have that this is only mild mitral stenosis. Depending on the body surface area, the normal mitral valve area is somewhere above 4 square centimeters. If it is below 1 square centimeter, we would call it severe, between 1.5 to 1, moderate, and over 1.5, it's mild. In summary, what are the problems with planimetry? First of all, you need good image quality. You can't perform it in patients where you can't really see the mitral valve. Alignment, we talked about that already. You have to really be at the tip of the leaflets. Oblique views overestimate or lead to overestimation of mitral valve area. Timing, you have to choose a frame which lies exactly at the moment when the mitral valve is at its greatest opening, in other words, at early diastole. Calcification, because of shadowing we cannot see usually the posterior parts of the mitral valve. Atrial fibrillation, simply because timing is more difficult. Incomplete commissural fusion, where you're not sure if the commissure is really fused or not. And finally, the most important part, you have to be very experienced and you need a lot of practice to perform planimetry. Actually, 3D echocardiography would be the ideal methodology to perform planimetry because there you could make adjustments in all planes. Image quality is maybe still a problem, but let's see what comes in the future. Maybe we'll use 3D echocardiography to perform planimetry in the future. Here's an example of what 3D echocardiography can also provide. This is a reconstruction of a mitral valve in a patient with mitral stenosis. You can see the mitral valve orifice here and the doming of the leaflets. And we actually use these data sets to reconstruct or build a model of such a mitral valve, and those are the corresponding models. What we learned was that not all patients have the classical form of mitral stenosis with a typical doming, but there are also patients who have a more funnel type of mitral stenosis. But let's go back to the actual topic, to the quantification of mitral stenosis. Can M-mode help? Well, actually it did. In the early days of echocardiography, we used M-mode to quantify the severity. One looked at the so-called EF slope, which describes the motion of the anterior leaflet during diastole. When you compare the slope to a patient with sinus rhythm, you see that patients with sinus rhythm have a much steeper curve. So thereby it was possible to quantify, or at least semi-quantitatively quantify, the severity of mitral stenosis. Other typical features that we see in patients with mitral stenosis in the M mode is we see a motion of the posterior leaflet which is drawn towards the septum, opposed to patients who have sinus rhythm, where this motion is contrary or mirrors that of the anterior mitral valve leaflet. While we used M-mode in the past, we now use Doppler. Those are two tracings of patients who have mitral stenosis. The only difference is this patient on the left has sinus rhythm and this patient has atrial fibrillation. Both have severe mitral stenosis. Here we have an A wave and here we don't. Practically, how do we obtain such a signal? Well, we use a 4-chamber view, and we use continuous wave Doppler because we're expecting higher velocities, and we try to align the continuous wave Doppler in such a way that we are parallel to the inflow. A tip, use the color Doppler as guidance. Thereby you can see exactly in which direction the jet really goes. Why do the spectrums look the way they look? Well, remember, the velocity tracings we see in Doppler only resemble pressure gradients. And with mitral stenosis, we have a pressure gradient between the left ventricle and the left atrium. Here's an example of a cath pressure tracing, and you have the ventricular curve here and the atrial curve here. And the area under the curve basically represents exactly what we see with Doppler, the gradient. We can obtain a maximal gradient and also, by using the integral, a mean gradient. Here's a schematic representation of a Doppler inflow signal in a patient with mitral stenosis. What we see here is we see a point where we have a maximal velocity. If we use the Bernoulli equation, we can calculate a maximal gradient. Now, the maximal gradient in mitral stenosis does not really represent the severity as good as the mean gradient. So what is actually better is we can use the integral of the velocity, in other words the mean velocity, and apply that within the formula of Bernoulli to obtain a so-called mean gradient. Away from theory, let's turn to practice. Here Here's a patient with typical mitral stenosis and a beautiful signal. And here I'll show you how to quantify the mean and the maximal gradients. How do you perform quantification of the severity of mitral stenosis with continuous wave Doppler? Technically, the first thing you do is you use the color, would be my recommendation, to guide your continuous wave Doppler. Then you align it to the color Doppler. You freeze the image and you trace the curve E wave, A wave, a patient with sinus rhythm, and we have a mean gradient of 5 millimeters mercury, so very mild form of mitral stenosis. How do we grade the severity of mitral stenosis based on the mean gradients? Well, the problem is that different countries have different cutoff values. For example, in the States, above 10 millimeters mercury would be severe, between 5 to 10 moderate, and below 5 is mild. In contrast, in Germany, for example, we have severe above 15, so not above 10, but above 15, and moderate between 8 to 15, and mild below 8. I personally prefer these cutoff values because not infrequently will you find patients who have gradients somewhere in the range of 12, 13, or 14 millimeters mercury who don't really have a severe form of mitral stenosis just based on the morphology and also on the pressure half time. So these are the guidelines I use, but you're of course open to use whatever you like. But what is more important than absolute cutoff values is the fact that gradients are very strongly dependent on heart rate and in particular cardiac output. So if patients exercise or if they're, for example, just anxious during the exam, this will raise their gradients. Another reason for elevated gradients if patients also have mitral regurgitation. Now this is a fairly frequent finding in the setting of mitral stenosis, as you can see here in this example. A patient who has mitral stenosis and additional MR. And since we have pendulous flow, in other words volume load across the mitral valve, the gradients are also higher. The severity of mitral stenosis can also be measured with the help of the so-called pressure half time. Now, what is the pressure half time? Well, basically it's the steepness of the mitral inflow curve in early diastole. To better understand the principle of pressure half time, here's an example. Imagine you have a room with a door. The door has a certain size, and in the room you have a crowd of people. Now the people all want to leave the room at the same time. It depends on the size of the door how quickly the people will be out of the room. So the size of the door is the mitral orifice, and the crowd is the blood flow, and the time it takes till the people are out of the room is the pressure half time. Actually, you do not need to wait until all the people are outside the door. It's sufficient if you wait, for example, until half the people are outside. Then you can calculate how long it will take till all the people are outside, and then you can calculate how big the door is. So back to our Doppler tracing. The steepness of the curve determines how severe mitral stenosis is. If the curve is very steep, then we have rapid pressure equilibration and we only have mild stenosis. If the curve is very shallow, then we have severe stenosis. We do not have to wait until this line really crosses the zero line. It's sufficient to look at the initial portions of the curve. In other words, how long does it take until half the pressure has dropped? That's where the name comes from, pressure half time. But be aware that we're not looking at half velocity, but half pressure. For example, we have a drop in the pressure from 25 millimeters to 12.5 millimeters. That would be the half pressure drop. But this corresponds to a drop in the velocity between 2.5 and 1.8 meters. We can then use this value in a formula and actually calculate the mitral valve orifice area. The specific value for the pressure half time that you get in a patient can then be applied in a formula. 220 divided by the pressure half time then gives you the mitral valve area. So why is 220 in this formula? Well, 220 is an empirically derived value which was tested or derived in a study many years ago where they looked at patients with mitral stenosis and they performed both Doppler echocardiography and catheter and then related the mitral valve area with both methods. And now we'll take a look at how we can perform a pressure half time measurement in our patient. To measure the pressure half-time, you also use a 4-chamber view, and you also use continuous wave Doppler. So here is how I would do it. Again, use the color to guide your continuous wave signal. Then you get a very nice signal. And then you just measure the slope of the descending part of the E wave. You do not need to pull the cursor all the way down to the 0 line. It's enough if you go somewhere towards here. And there we get an opening area of 1.8 square centimeters. So very easy to perform. However, look what happens if I just slightly change the slope. You get very large variations in mitral valve area, ranging from 1.5 even to maybe even 2.1, just by changing the slope just slightly. So it's a very sensitive parameter. Keep this in mind when you perform the pressure half-time. The color Doppler signal is not only helpful in the detection of mitral stenosis, you can actually use it also for the quantification of the severity. If you have severe mitral stenosis, you will have a lot of flow convergence in the proximal region, here in the area of the mitral valve, opposed to patients who only have mild mitral stenosis. Unfortunately, this calculation is fairly complex. What we do is we relate the mitral volume flow to the peak velocity of diastolic mitral flow. We need the size of the aliasing. We need the aliasing velocity, which you can read on the scale in the machine, the peak velocity of the mitral inflow signal, and thereby we derive the mitral valve area. Do we use it in the routine practice? Well, very rarely actually. Why? Simply because we have other methods available which, to my opinion, are more reliable and easier to perform. Finally, another method we can use is the so-called continuity equation. You can see the formula here, which is fairly complex and which does have the problem that it does not work in the presence of aortic regurgitation and mitral regurgitation. And since regurgitation of the aortic and mitral valve are present very frequently in patients with mitral stenosis, we do not use it. In addition, it's just very complex and there are a lot of measurement errors involved. The continuity equation has much more importance when we come to the calculation of the aortic valve area. We'll see that later. What about quantification of mitral stenosis in the setting of atrial fibrillation? Well, first of all, atrial fibrillation is very frequent in mitral stenosis, and yes, we can quantify it. We have to consider a few things, however. First of all, as we talked already, planimetry should be performed with several measurements and averaged, and the same is actually also true for mean gradients. You should average 5 cycles, and you should try to find cycles where you have fairly equal RR intervals which are close to the normal heart rate. The same is also true for the pressure half-time, where you should also average several cycles and where you should also use cycles where you don't have a diastole which is very short. Coming back to the pressure half-time, what are the pitfalls and where do you have to be careful? Well, first of all, diastolic dysfunction is not the ideal setting to use the pressure half-time. Why? Well, simply because the pressure half-time is not only influenced by the size of the mitral valve orifice, but also by, for example, the compliance of the left ventricle. And the compliance is reduced in diastolic dysfunction. So you will have a fairly flat curve, or you at least have a longer pressure half-time in the setting of diastolic dysfunction, and that can lead to overestimation of the severity of mitral stenosis. As a result, you should not use it if you have diastolic dysfunction or if you suspect diastolic dysfunction. Another problem is aortic regurgitation. In that situation, you have additional backflow into the left ventricle during diastole. So you have a quicker equilibration of the pressure between the left atrium and the left ventricle as well. The curve of the mitral valve inflow signal is steeper. Therefore, you will underestimate the severity of mitral stenosis. Pressure half-time is also not very reliable, or at least it does not reliably reflect the mitral valve orifice area immediately following valvulopathy. In this setting, you should be using the mean gradients. The shape of the mitral inflow signal can also be a problem. For example, if you have a concave shape, it might not be possible to measure the pressure half-time. Finally, the pressure half-time can also be unreliable in the setting of degenerative calcified mitral stenosis. Such patients often also have diastolic dysfunction. One thing which is important to know is that the formula for the pressure half-time was tested in young individuals. We do not know if this formula and the correspondence or correlation between the pressure half-time and the true mitral valve orifice area really also is true or accurate for patients who are much older and who also have additional problems such as diastolic dysfunction and calcified valves. Here are two examples to illustrate the problem with diastolic dysfunction. On the left-hand side, we have a patient with mitral stenosis, but where we do not have an A wave simply because the patient is not in sinus rhythm. So we have problems to really know if diastolic dysfunction is present. We cannot use E to E prime as well. But what we see is that the patient also has left ventricular hypertrophy. So in this setting, I would be very cautious to use the pressure half-time method. Here on the right-hand side, everything is quite clear. We have a relaxation pattern. So this patient does have diastolic dysfunction. In addition, we see that the patient also has left ventricular hypertrophy. Another problem we see fairly often is that we have an interference between the AR signal and the mitral valve inflow signal. You can see here aortic regurgitation, which is eccentric, directed towards the anterior leaflet, and thereby mixes with the mitral inflow signal. Thereby we get a very difficult to interpret signal in the pulsed wave or continuous wave Doppler. It's very hard to actually see where the contour of the mitral inflow signal is, and thereby very difficult to calculate mean gradients and the pressure half-time. This problem is fairly frequent simply because we have a very high association between aortic regurgitation and mitral stenosis. In this situation, you just have to play around with the transducer and try to find a view where you can better delineate the two signals from each other. So in conclusion, I think you were able to see that we can look at very many different things with echocardiography to quantify the severity. However, keep in mind that all these parameters have to fit to each other. You cannot have a parameter, for example, like the mean gradient, which is very high, and a mitral valve orifice area with planimetry, which is very large. It just simply does not fit together. Ask yourself the question, why is that so? And look for other problems the patient might have. And also, of course, ask yourself, how symptomatic is the patient? Does it fit to the degree of severity that you, for example, are diagnosing with echo? Now we'll turn to how we can treat these patients and how echo can help us to decide how we can treat them.